wanted to give a simple approach. I should have written the word simple. I wanted to give a simple approach to an infertile couple. And as you know, that currently we don't only, the topic I was given is infertile couple. Maybe I would have named it differently, but I didn't want to be disrespectful because we don't only see couples coming in for infertility, but you do find single people as well. And you even find, and it depends again on your definition of what a couple is. So that's the topic we'll be discussing today. I'll try to keep it as simple as possible, just for you to not be daunted by somebody coming, sitting in front of you saying, I've been trying to have kids and I've been failing for the past 5 years. And you're like, shucks, where do I even start? Do I go test the tubes, or do I do bloods, or do I, where exactly, what is the approach? So who would come to you asking for a fertility check or wanting to have kids? So it's couples who are heterosexual. A man and a woman can come in. It can be a couple where a woman comes alone. Most times that's what we see, where it's a heterosexual couple, 50% represented, because men are not fond of these checkups. They either are too shy or too proud, or most of the time they usually think they are not part of the problem. But we'll see what statistics say about that. And then we also have same-sex couples that come in. So it can be two males that come in saying they would like a plan on how they can have their own child. And should time allow, we will discuss just a simple approach to this as well. But obviously, it would be a practice that will be engaging a surrogate and at least one biological parent. And also you get a lot of advanced age individuals. So women above 40 waking up to say, hey, I never thought I wanted kids, or hey, I just got married now, I was waiting for marriage, or hey, I've just become a professor and now I'm ready. People will come and sit and say, doc, I'm ready at 44. Doc, I'm ready. The family can come now. I've made it to partner, I've joined the firm, or I'm now a CA, whatever it is that they've had as a career goal, and now they are ready to start their family. But yeah, as we know medically, that as the woman's age advances, then her eggs decrease. And this is something that we need, a message we need to send out there to our women, a message that we need to preach on a daily basis, that, hey, as bad as it sounds, as much as we don't want to be the bearer of the bad news, but the biological clock is real. It's a reality. And you also get single individuals. There are women out there who are fed up. Fed up. They come in and they're like, hey, Yazid, I don't care. I just want a baby. I just want to be a single mom. It's fine. Other things, what the baby asks me and whatever, what people say, I don't care. I just want a baby. So you need to help these individuals as well. And then also those with their chronic diseases must not be eliminated. Patients with HIV, we need to know, this one is straightforward and simple. I'm not even discussing it in my further on in my presentation. HIV positive patients, we just need them to be virally suppressed. That's all. As long as they are on their medication and they're virally suppressed, we're good to go. So they should not be excluded or discriminated against. And then cancer patients, if you have a patient who has cancer and they are young, please remember they need to preserve their fertility before they go on that chemotherapy or radiotherapy, whatever it is. So Any patient that has cancer and needs to go through these fertility declining medications or treatments, let's consider saving those eggs first or preserving those sperm before they go on their treatment, as much as we have time available. So please engage fertility specialists in time, because they go on to regret and they go on to blame the medical practitioners as to say, why didn't they tell me that they're making me infertile, you know? And you get the poor and you get the rich. It does not discriminate. The poor do come for fertility, and they unfortunately are the worst off, because fertility treatment or assisted reproductive therapy actually comes at a high cost, and that's the biggest problem that we are actually facing. So what does infertility mean to patients, or what is infertility to patients? To them, struggling to conceive, you know, is like a silent killer in their lives, you know, killing their hopes and killing their dreams of becoming mom, or of becoming dad, or of having a family, or having a big family. It could be primary infertility. You know, you would think secondary infertility, where a person has one child at least, or has two kids at least, would be better off than somebody who has primary infertility. You know what? Once the diagnosis is there, it's a silent killer. It comes with depression. The person doesn't even care that, no, at least I have one child. No, most times you find that they have two kids, and maybe it's the end of the relationship ended, they're in a new relationship, and it means a lot to them to actually have this one child. Guys, you must understand, you know. So that's very important. It also comes with shame, and it's a sign of failure for many patients. So understand, when these patients sit in front of you, they already, it's not easy for them to come and ask these questions. It's not easy for them to come and be assessed for something that should be happening naturally. So already psychologically, they are beaten. Already psychologically, they are defeated. They feel as failures. They feel as if they've put a shame into the family. Pressure from the in-laws, pressure from friends. It leads to social stigma and criticism. Stigma where people get called names, inyumba, or a woman is called Mr. So-and-so because she cannot fall pregnant. Therefore, you're just like a man because you can't fall pregnant. It causes mental and social dysfunction to patients. So already they are socially affected. They no longer go to baby showers. They no longer go to family functions. They're already keeping themselves to the corner. They're isolating themselves. Mentally, they are disturbed. So these are all the effects of infertility. It's also a source of gender-based violence, and can even lead to death to some, where mostly it's men who believe that this woman cannot bear me kids. I married you so that you can bear me kids and increase my surname and whatever, you know, and it ends up resulting in physical violence, and some women die. And a big source of divorce. Marriages get torn apart because of infertility. Marriages break down, families break down because of infertility. And it's also, even then, when they try to go and look for help, only to find that, hey, this is a mountain to climb, because you don't just go to a doctor, you get a pill and your problems are suddenly sorted. You also need a serious financial investment as a couple. People end up selling their cars. People end up breaking their kitty banks and all of that. So this is what infertility presents to the people or the patients who will be sitting in front of us. What is infertility to us? We have a definition. Infertility to us is a disease of the reproductive system. It's one of the diseases. So it's a disease of the reproductive system. It can either be a male or a female. So we argue a lot. We're still trying to get many medical aids on board, because medical aids do not accept or recognize or acknowledge infertility as a disease. That's why it causes it allows for patients to pay from their own pocket, because they say wanting to have a baby is not a disease, it's actually a luxury or just a need, but you're not physically sick. But according to the WHO, infertility is a disease of the reproductive system. It can be a female or a male reproductive system. And we say a couple is infertile if they've been trying to conceive for 12 months with regular contraceptiveless, meaning no contraception being used, including a condom. Please clear this out with patients, because to them, you say, have you been using contraception? They say no, and you be like, a condom? Oh yeah, we've been using that. It's also part of contraception. So if they've been using no contraception or unprotected sexual intercourse regularly for at least 12 months, if the person is less than 35 years, the 6 months, if more than 35 years, that's the arrow should be looking the other way around. So it should, the bum of the arrow should be facing 35 years. So if they are more than 35 years, only 6 months, and then they qualify or befit the definition of infertility. That's the WHO definition, okay? And you'll find that it's actually becoming more and more common, because we as women want to do it all, and we want to climb that corporate ladder, we want to achieve our goals, or we're just not finding the right person, and then we end up delaying. So what can we say? It's as common as 1 in 6 to 7 couples in developed countries, and much more common in underdeveloped countries and developing countries, as in it is 1 in every 4 couples. So we're talking 15 to 25% worldwide, and 25% in underdeveloped countries. So that's mostly us. And the underdeveloped, I would say, it's more common, mostly because of pelvic inflammatory diseases leading to obstructed tubes, which then lead to infertility, and PID, mostly commonly associated with STIs and all of that. So to a certain extent, there is some socioeconomic status relevance here, because 25%. So if we're going to a bride, can start counting there in where the couples are, like 1, 2, 3 infertility, 1, 2, 3 infertile. That's how common it is. So this now becomes a problem, because this is the right of individuals to found a family, to start a family. It is their human right to found a family, and they feel that this right is being hindered from them. Blame it on the gods, blame it on the medical field not making fertility treatment cheap, blame it on the spouse, blame it on anybody or anything. Okay, and then we go on to tell them that, look, even as they start, it's very important. Sometimes you get patients coming in, they are newlyweds, they're excited. We just want to check. We've been trying for 3 months, we stopped the pill. There's absolutely nothing wrong with that. Sometimes I actually commend them for coming in early, as long as they can afford it. I say, wow, why wait for 12 months? Why try for 12 months only to be told after 12 months that, hey, whereas you could have started with a solution already, So for those who can afford, they can start, but it's very important to reassure patients to say, hey guys, fertility is not a matter of opening legs, doing the deed, and the next thing, the baby is there. It takes about a year for 84% of the couples to fall pregnant. So this month you may try on time everything, but the egg just goes nah, or the sperm just says, I'm not ready, or I don't like that one for whatever reason. But 12 times in a year, 84% of the couples win. And within 2 years, only 92% of the couples win. So don't feel bad. Okay, so that's part of the reassurance that we can actually give to our couples to say, hey, it takes about 12 months for the majority. I'm not happy with the way this slide is showing, but I like it because it simplifies everything. I think it's something that a slide that's very important for us to have in our practices. Just something like this. You know, I personally believe that an informed patient is an empowered patient. An informed patient is an empowered patient, because then he or she is able to make the right decisions. You're not the one saying, Hamburg's HSG, Hamburg's Semen Analysis, Hamburg, you know, like you're dishing out grocery list or whatever, and they go. Once they understand and they become part of the decision making, they become part of understanding the problem, and they understand why they need to do things, it becomes very easy to deal with patients. And it takes less than 5 minutes for us to get them on board, get them to understand. We mustn't sit to them as the God of knowledge, you know, and you know, we bring them on board, we speak to them in layman's term, we make examples to them. And then once we spend that 5 minutes doing that, it will be so easy to say, HSG, this, and they'll understand and they will do it. Most times they walk out of your office and never come back because you're busy talking gibberish to them. They don't know what you're talking about and why do they need to do this? Why don't you just give them a baby? Most times they think they're gonna walk into your office and you give them a pill and the problem is fixed, you know, or you lie them down, you touch them there, hallelujah, the problem is fixed, you know. So all these things that we are asking for, you know, to them, it just doesn't make sense. So just 5 minutes of having a talk, let them be at one level with us. Why? What is baby making? So, and they love it when I say that, let's have a baby making chat, you know, and I pull out this chat and I promise you, they'll be sitting like this, waiting for me to come with all the information. The moment I say, let's have a baby making chat, and I put this on the table, then suddenly you see them going like this, you know, and they want to see and they want to look, and even the men included, then they want to like, Kanti, what is this thing that's so difficult? Because, you know, we've been trying for so long. Kanti, baby making. I thought it's a straightforward thing, you know? Then you take them through this, a simple thing. And then they'll be like, oh, maybe that's where I'm missing it. Then they'll be the one giving you the answers. Maybe I must go test my tubes, Dr. Ne. Will be like, yeah, you know, you're getting it. Ish, doc. It means, what if my people can't swim? What if my boys can't swim? Ish, you know, then you've got the men on board. Then you're not like a dictator. You're working with them. And then they're the ones now that are volunteering to go and, you know, do the test themselves because they've got a basic understanding of baby making. So we take them through this slide, and I usually just say, look, from a woman, we need mainly 3 things. The 4th one is hormones in the brain, but that's not a problem. We'll do blood results. We'll do bloods for that. But the reproductive system in a woman, we need mainly 3 things. It's the egg, it's the fallopian tubes, and it's the womb. Okay, sharp. Now, let's look at the ovaries. The ovary is where the eggs are kept. I'm talking layman's term. The ovaries is where the eggs are kept. Now the eggs, they start small and they grow. Women are born with a fixed number of eggs. We are made with about 4 to 6 million, but by the time that we are born, we've got about 2 million eggs that are left, you know? And then by the time we reach the age of 12, there's already about 500,000 eggs that are left. A woman loses 30 eggs every day. So it trains yamakanda, let you buy every day. A woman loses on a daily basis. On a month, a woman loses about 1 million. Now, the sad thing about that is that a woman is born with a fixed number. And the difference about the eggs is that they are not like hair. Hair, you can shave it off. 3 days. It's like, you know, I'll be having hair. If I don't shave tomorrow, I'll be having hair. I'll be putting manure, products, whatever. My hair will grow, but eggs are not like that. Eggs are like an arm. You chop it off, they're gone. That's it. There's no regrowth, you know. So, and the moment you say that, because Vele, you know, they're going to ask you, can't you give me a tablet that will regrow my eggs? Ever to, you know. So you tell them up front, this is the story, Samai. You move on to the fallopian tube. Now, one best egg is released. The one that becomes the biggest size, the best mature, is released. All the others die. It released and it waits here at the beginning of the fallopian tube. It's going nowhere. It waits. Now, sperm is deposited in the vagina and you point to the vagina. Now they start understanding, shucks, the egg is so far. And the sperm is only dropped, and because they know that's where they've been dropping the sperm all along. So the sperm is dropped in the vagina. Now the sperm needs to swim all the way up through the womb. That vagina is acidic, bro. It needs to survive that acid. Go up through the womb, through the fallopian tube, towards the end of the fallopian tube. And that's the only place where it meets the egg. If it does not reach there, it does not fertilize. We do not get a baby. If it gets there and there's no egg, there's no fertilization, we don't get a baby. Now, that sperm can survive there for 5 days. So it can wait. But that egg stays there for only 24 hours. And if you don't know when your 24 hours is, you miss it. Unless you had deposited at least 3 days before or on the day or the day after, whilst the egg is there for 24 hours. If you miss that period, that's the period we call the ovulation period. So if that period is missed, so suddenly there is an interest of this 24 hours. I've got 24 hours in a month. How do I get there? Now the questions start coming. Now the curiosity, now the interest. What is going on? How do I know about this 24 hours? Now they want to go buy the ovulation kit. You don't have to tell them to buy an ovulation kit. Guys, this is fun. I don't know, maybe it's just me enjoying my job. So what causes infertility? So, and yeah, outside popular belief, there is more or less equal causes of infertility between male and female. So we're looking at 30%, 30%, but if you combine the mixed causes where a male and female factors are involved, we've got about males being involved in 50% of the time. So this myth of saying infertility is because in infertility, it's usually the woman who has the problem. No, it doesn't stand true. And then there's still 20% of unexplained causes of infertility. But you know, guys, it's so sad because most times it's really this 50%. Most times you'll find that a woman comes with PCOS, for example, and the guy has oligoastenospermia, you know, or the guy has azoospermia and the woman has some form of endometriosis or blocked tubes, or, you know, at some point we end up going, hey, do they attract each other somehow? It's like, you know, infertility coming through people, you know, attraction forces of some sort, because usually you find that it's both, like my attractor, like, you know, but it's really sad. But that's the common findings, hey, that you find there's both male and female, and then we need to attend to both, which is why it actually becomes very important that you don't only treat the female. One female, one of my fibroids, so yeah, this is the fibroids causing the problem. She goes under the knife, wara, hey. The next thing, she comes back after a year, after 2 years, there's no baby. Then only when the guy is tested, he's been sitting on a problem as well. So we need to test both. You may find that you will women will not be going for lab scopes and all these things if we were able to just test both at the same time. Then you don't do that lab scope, you find that it's a sperm factor, straight IVF, guys. You know, and we save women a whole lot of trouble. But I do understand, you know, some women come in and say, hey, I just want you to test me first. Hey, make sure, you know, before I just want to make sure on my own. You know, there are some people like that. So we can offer them that benefit of the doubt if they want to be tested alone. Men become fearful, but yes, some actually just first go via the urologist before they come into us with their partners. So these are the common causes. And it's also very important to explain this to the couple. It may seem like a lot of work, but guys, believe you me, it makes life so easy. I remember attending an MPS course, and it was about litigations, medical litigations. And it was, we were asked, how long do we think it takes for a consult, a doctor to take a history from a patient or to listen, main complaint? How long do we take to listen to a main complaint? And we're like 5 minutes, 15, 20, you know, some patients will be telling you what they had for breakfast and the night before, and, you know, and it was said that a typical patient just talking and giving a history of the main complaint takes less than 2 minutes, you know, without the doctor interrupting. But that's the time that we don't even feel we can give the patient, because already we are guiding them. We know where we want to go, because they just said they had this for supper, because they think it had a bearing on what they're coming here for, you know. So us also just spending a few minutes of educating the patient actually goes a long road, because it also, so I'm here, I'm not just educating us as colleagues. These are discussions that we have as patients, because it empowers them and gives them a reason as to why they need to do it. So already they know that the sperm needs to swim. You know, I'm like, a sperm needs to have a nice tail like a kite. You know, when a kite doesn't have a tail, and I'm like, you saw the long distance that that sperm needs to swim, and the guy's like, yeah. Because by the time they come in there, they're already refusing to give us a semen. They've told us, the partner, I'm going there, I'm going to support you, I'm not doing anything, I'm not giving any sperm. But the moment they see that the boys need to swim such a long distance from the vagina to the fallopian tube, it's very important. Then they want to know, yeah, no, it fulfills it. And then you explain that the head of the sperm is also very important, because that is what is used to penetrate the egg. So it needs to break through the eggshell. And at the tip of the sperm, do I have this? At the tip of a sperm, there is a copy here that sits as an acrosome. It's called an acrosome. And that's like a driller into the egg. Easy stuff to remember. So if you're not driller, you can't drill into the egg, can't go in. You just bounce there, you just bounce. So we need to make sure those hairs are fine, you know. And the concentration of the sperm count as well. The sperm, they work like boys, you know, group action. And they release these chemicals that reach the egg and soften the eggshell before the right boy goes in, you know. So if there are too few, then the eggshell is hard and it can't be penetrated. So it's very important. This is explaining to the men now that the shape of the sperm matters, the swimming ability of the sperm matters, and the total sperm count is also very important. So that's why we need the boys to be tested. And these are the common causes of infertility. This I usually don't discuss with males unless maybe I'm taking a history. Have you been have you had any prior surgical history? Have you had testicular problems, STIs, orchitis, all those things? So sexual dysfunction, that's what you take from the history as well. Chemotherapy, all of that, because it affects the quality and the quantity of the sperm. Now, this is for us. that we need to be aware again that the sperm parameters have changed. Some of the labs have not updated. This was last year, I think last year, July, if I'm not mistaken, where WHO released the new parameters. But you'll see not a lot has changed. When we look at the volume of the sperm, some men are shaking, they spill the sperm from the container, or they mess up or whatever, but we need a sufficient volume of at least 1.4, it used to be 1.5 mils of sperm. Then we know that, okay, the volume is sufficient. Then we look at the total number of sperm. We need about 39 million sperm to, I always say that, 39 million sperm to fertilize one egg. And you're like, basali kibozo. 39 million sperm to fertilize one egg, you know, and we need at least 42% of them to be good swimmers, to reach up there in the fallopian tube, at the tip of the fallopian tube. So that used to be all the way from 2010, it used to be 40. So more countries were added and more studies were done. And now it's sitting at 42% of them need to be able to swim. So at least 42, you can father a child, you know, I don't talk 100% or anything, you know, the whole 58% of them can be sleeping, but if those 42 nje can reach that area, we can have a success. And we look at progressive motility, and we need at least 30% of them to be able to swim forward. But if we look at the total motility, it's sitting at 42. Then very important, it's the normal forms, the morphology. So 3 main things that are key. It's the total number of sperm or sperm concentration. You can look at either or. And then you look at motility, which is the swimming ability. You need 42%. And then you look at the shape of the sperm. It's the number, the shape, and the swimming ability. So you look at the shape of the sperm. The whole 96% can be sleeping, at least. Studies have shown that even men who had 4% of normal sperm were able to father a child. So if we have less than these parameters, then we have abnormal sperm factors. When the sperm is low in normal forms, it's the morphology, okay? And that is what we call teratozoospermia. And then when the sperm is low in swimming ability, it's actinozoospermia. And then when the sperm is low in number, it's oligozoospermia. And when all 3 factors are affected, it's oligoactinoteratozoospermia, which we call oats, like the jungle oats that we eat. So OAT, oligoactinoteratozoospermia, oats. So when I speak of oats, we mean all 3 factors are affected. That one you send straight to Dr. Diale. So how do we approach a male that is infertile? So let's not forget, history taking is very important, just from the history. That sometimes men know their problem. They can, just from the history, you'll say, how old are you? He'll be like, I'm 36 years old. I had undescended sperm at the age of wara. I was operated. I was told that the testicles were found to, you know, and they're done, just from a history. You know, so it's very important to go through history, find out if there's sexual dysfunction and all of that. Then do a physical exam as well. Look for gynecomastia and check their BMI, because male obesity also does play a role, guys. It's important in cover. Yeah, I don't want to say much, but yeah, that one pack needs to go down. And undescended tested. So especially us as gynecologists, you know, we spent so many years not touching men, you know, and we are enjoying it. And then suddenly you are doing infertility and you've got a man in front of you, and a man becomes your your patient, you're like, ah, and then the woman needs to sit there watching you. I'm not gonna say fiddling or fondling, but you're doing that. You're examining her partner's testicles and penis and all of that. We have to. I must say, I found it very daunting at first. I'm like, now I can see the semen analysis results because, now I can't just say there's no sperm and I didn't even check if there are testes in there. I have to. So, guys, zifiki gora lapha. Hi, guys. It's very uncomfortable, but hey, it's part of the job. We have to do it, guys. We can't send people through without examining them. So please test that man. Look at the size of the testicles as well. Some have got atrophic testicles, and you can tell with inking corner shame, or you feel them swollen and you can feel the varicocele, the dilated blood vessels around that, because already so it diagnosis right there. It's a varicocele, sent to urologist, they sort it out. People can fall pregnant naturally without further intervention, as long as when the good doctor who does a physical exam has been able to pick up the varicocele. So it takes two to tango. Okay. And then you do the semen analysis. I've gone into length on the semen analysis. So if it's abnormal and it's a mild type of abnormal, I'll explain what that means. Then you can give them supplements. You can ask them to do timed intercourse. You tell them, teach them when ovulation is for the female, and then do the semen analysis again in 3 months, depending on their age. If 3 months is okay, they're in their 20s, early 30s, then yeah, it's okay. But sometimes, it's an advanced age couple, and I feel, okay, let's just repeat it in 6 months. If it's still giving me abnormal values, then we need to intervene. Okay, so there are many products in the markets that improve sperm motility. Not going to speak much about it, but you can then, if there's no improvement, please, the earlier you refer to a fertility specialist, the better. Because if you spend a lot of time with them again, they end up thinking, these doctors don't know what they are doing with us, they're wasting our time, they lose hope, But if you say, look, there is this, and then others come and say, oh, money was never a problem. I spent 10 years not getting help with my wife. Now she's 45, and had I known earlier, and there's nothing we can do now. She no longer has eggs, and it's really sad, guys. So the quicker you can send them through, don't spend too much time with them. Just send them through. So sperm parameters, if you want to do an intrauterine insemination, you need a good sperm concentration and a good motility. So motility should be more than 42%, and at least the sperm should be more than 4 million. Other scholars say 5 million at least. So you need at least 5 million sperm to try an IUI. If you have sperm that is less than 5 million, motility that is less than 42%, guys, rumela yena, fast forward, send to the right door. Don't waste their time much further. Just say, Wena, you're not for me. I'll send you to a fertility specialist who deals with this, who specializes with this, and make the fertility specialist look good, not as a god, but make them look good, make them look forward to say, hey, there's a doctor I know, works more on this, they specialize in this, they are super specialists. If I send a patient to a MAFO specialist, Nami, I make them look good. But no, this is an obstetrician and gynecologist, but they've studied further and they've super specialized into abnormal pregnancies, high risk. Make your colleague look good and send your patients there. They'll come running, they'll come with good spirits, not depressed already, because already they are defeated in the mind. So make us look good, guys. They've super specialized, they work specifically, day in, day out. So if the patient has got azoospermia, you send them straight away. It will help if before you send them or as you send them, you just do an FSH, LH, and testosterone to check, for us to check whether it's just a testicular issue where we know we won't find any sperm, or is it a hypo where we need to give them some medication and then boost their production? Okay. And then I spoke about oats. If you see an oats, multiple parameters affected, straight to a fertility specialist. You don't sit much on them. Yeah. Rumela. So that's as far as male is concerned. So we got all of that. And then causes of female infertility. What could be wrong? As I said, with the female, we're looking at the brain. That's it simplified. We know a thyroid is sitting here, guys, but you just think endocrine and the prolactin levels. Okay, so main thing is prolactin and the thyroid. You don't want to be embarrassed or you didn't check for thyroid levels and the woman is actually having irregular periods, not because of PCOS, just because of a thyroid issue. And when you know, so just basics. Remember the thyroid and the prolactin levels, okay? And then we go to the actual reproductive system. And again, even as you talk to women, you take them by the system. It's the ovaries. They can be affected by age. They can be affected by primary ovarian insufficiency or premature ovarian failure. And then you go through the tubes. The tube can be blocked from STIs, pelvic inflammatory diseases, or even endometriosis causing external blockage, or there could be internal disease in the tube. So and remember now, because you've showed them that initial diagram, now, if the egg is sitting here and waiting for the sperm, and the sperm comes swimming all the way up, oh, roadblock. There's no meeting. So we don't get a baby. So we need to know what's happening in the tube. That fallopian tube must be open. So then a long story, hey, I won't tell you my long stories with my patients, but then endometriosis can affect, fibroids can be a cause as well, mostly of miscarriages or preterm labor, but if they are sitting also here, they can cause obstruction. And if they are what we call grade 2 fibroids right here close to the endometrium, they can also cause fasciculations and lead to pregnancy loss. So how do we approach a female? We take a history. Again, it's very important. You start from her menarche and how her periods are, how many days she bleeds for. The moment she says she bleeds for 7 days, you're already having your mind going towards fibroids, you know. The moment she says her cycle is like 36 days, 38, you know, you're already going towards PCOS and all those things. So history is very important. History is also very important. Obstetric history is also important in the male, let me mention, because hey, guys, where you know a woman is para 0, the guy is para 1, and they've been trying for the past 10 years. The guy is para 1 and the child is 1 year old. We'll be like, you would also need a moment to breathe at some point, you know. So it's important to get parity from both sides and the history. The other couple told me, I asked the woman, no kids, we've been trying for 9 years. And then I'm like, okay, sir, do you have any children? And then he looks at the woman and then the woman looks out the window. So it's like, and then I'm looking at both of them. And then I'm waiting. And he's like, yes, but no. I'm like, what do you mean? What answer is that? Well, the child is not born yet. You know, you even feel like hiding under the table. Okay. When is the child being born? The child is being born in October. So that child is still coming, guys. But they've been trying for 9 years. So it's very important also to find out when a woman says she's got 3 kids, is it with the same current partner or a different partner? Because you may find that this current partner is para 0 and this woman is para 2. And maybe the problem could be with the guy, maybe not, but you know, you try. We are like detectives here, you know, and trying to put the story together, because I tell them, look, at the end of the day, we're going to put all the pieces of the puzzle together and we're going to say, aha, you are the culprit. So that's the whole aim, and we treat the problem. Do a physical exam on the woman. A BMI is very important. Women with a BMI of more than 30, you struggle even with IVF, because you need to pinch the skin on the abdomen and inject medication. Now, if you're going to be pinching a whole lot of fat like this, you know, it becomes difficult. Then we need to double the dose or increase the dose at some point for it to be able to reach the bloodstream and into the ovary. And when you explain that to the patient, they understand better. So some of them, we say they can inject on the thighs. And there are many reasons why actually BMI does affect or reduce fertility. Look for hirsutism, look for acne, look for a shield chest, look for galactorrhea. Please don't be embarrassed. As I said, prolactin is important, and also you're just squeezing the breast to make sure, excuse me, that there is no breast coming out of there, breast milk coming out of there, or fluid coming out of there. Sauna, very important. Please look at the endometrium. The thickened endometrium, irregular endometrium, there could be polyps, there could be fibroids on the myometrium. And you look at the antral follicular count, you can even see polycystic ovarian morphology of the follicles there. Then you can put your whole diagnosis together if you are picking up features of PCOS. Now, when it comes to the bloods, please make sure that the reproductive or endocrine bloods are done on day 2 or day 3. Don't just send them randomly to go and do bloods. If you want to get immediate results now, you're sitting with a 44-year-old who's hopeful that she's gonna fall pregnant as in tomorrow, you know, then you can do to the end, you can go same day to what I put as endocrine and infective, where prolactin and TSH doesn't need a cycle day, and AMH doesn't need a cycle day. AMH can straight away tell you that the reserves are low. Okay, then you know. And so if you've done a nice physical exam and you have an antral follicle count of 1 or 2 or 0, you just see fibrosis in the ovary, and you get an AMH and it says 0.05, you already know where you're sitting, you know, before you actually do these day 2 bloods. So these are very important for you to do. This second row does not need a particular cycle day. But if you do a FSH on the wrong dates, then we'll end up even diagnosing perimenopause. Kanti, the poor woman, you know, was just going through a regular cycle. It's just that it was a wrong timing of a cycle. So just quickly for you, we expect on day 2 or day 3, the FSH and LH to be less than 5. And the estradiol must be above 80. So this is basic. So once you have high FSH and LH, we know that we diagnose menopause once the FSH is above 25. So if already the FSH is sitting at 20, guys, you'll be like, yeah, but we are approaching. So I even draw for them with a resting, I call FSH a manager, a supervisor. So if the ovary is working well, that's the employee, and releasing estrogen and releasing eggs, the supervisor will relax, will chill, will be less than 5, no problem to stress. The employees are working. But once the employee gets lazy, supervisor will be like, hey, shouting, you know, starts being active. Then it moves from 5 to 10 and 10 to 15. And then when the employee is like, you know what, I resign, I'm out of here. There's no function at the level of the ovary. FSH will be so frustrated sitting at 25 and above. So when the patient see that a relaxed supervisor is less than 5 and a frustrated one, meaning there's no work happening, that's menopause 25, and you show her hairs is sitting at maybe 30, then she's convinced I have menopause. Sometimes it's sitting at 70 and she's coming to you thinking, no, then she gets it, I am farming, you know, or she's sitting at 24. She just, you know, then it's easier to speak about donor sperm that way. Hey guys, I'm taking time. Fallopian tube patency, it's very important. Now you find people, hey, we are loading people with letrozole. Can't the tubes are blocked. You're wasting the money. You know, IUI is about 6,000 rand. Let's say maybe it's a single lady and she comes and she wants sperm. Then it's already 11,000 that she's spending on that cycle, only to find that her tubes are blocked. You could have taken that money, done an HSG. It's a first line treatment. Then you know with Musadi, next step, this bus has passed. You know, the tubes are blocked, unfortunately. You know, if she's seen your diagram, you are able to say, okay, you see, this is what is happening. So the egg is not meeting the sperm. We need to find another way of actually making the two meet. It's just to meet in J. We're not doing funny things in the lab. It's just to cause a meeting area. Then we put the babies back in the womb. We just use, you know, the reverse route, and that's it. But if a person has things like chronic pelvic pain, endometriosis, you are suspecting pelvic adhesions and all of that, then a lab scope will achieve more. Then you do a chromoperturbation where you put in the dye. Please, we use vitamin B co if you want to see, but just plain water. Mina, you know, you just lift the uterus, the tubes are hanging, and you can see plain water, drop, drop, drop. It's simple. We're not that blind as yet, I hope. But if you want to see something colorish, then you can color your fluid with vitamin B co. So when do we refer to a fertility specialist? Once there's if you have confirmed patent tubes and you've done ovulation induction and IUI at least 3 times. If you trust your IUI skill and measurements and all that, you can go to 3 times. But sometimes I think it's better to leave the IUI even to fertility specialists. If we have time, I'll take you through IUI. If we don't, it's okay. You refer when there's blocked fallopian tubes. You refer when there's abnormal sperm parameters. You refer when there's a low ovarian reserve, an AMH of less than 1. Rather refer that patient. If there is advanced maternal age, women that are trying to conceive, they're above 37 already, you can see if they are willing to go this route, and rather maybe their IUI be done by a fertility specialist. Women with primary ovarian insufficiency, because we need to discuss the condition with them. We need to discuss the options with them. Some of them are very defeated and negative, and you know, but and it's straight, they want to go to adoption, and you know, adoption is good, but it's different when the baby grows in your womb and you are involved and your partner is involved in the process with you, and you are the one that gives birth to this baby, you know, and you go through the emotions and you're bonding with this baby, kicking inside. It's different. I don't know, maybe but I speak to them and I'm like, it's a big difference going to a baby that's already made. You don't know what that mother was drinking during the pregnancy. You don't know, you know, a whole lot of things. And, you know, so at least to know that at least one biological parent is present and the other one, you're not sure, but we give you the profile of the donor. You know, she's this tall, she's this is her qualification, this is her complexion. You get what I'm saying? Then someone you know nothing about and you're not involved, you get a ready-made product. So I love adoption. Nami, when I grow old, I'm going to adopt. But for patients, they feel a bit, you know, consoled when you discuss the difference of adoption versus donor egg donor, and the need for egg donation, and those that need sperm donation as well. I don't think I still have time. I thought this presentation was short, but there's PCOS and IUI and then a summary. I don't know.
Continue, Doc, maybe for another 5 minutes and cover highlights of these 3 slides. Thanks.
Okay, so we do face patients with PCOS. Biggest problem, those with the BMI of more than 30, studies have shown that they do benefit from metformin. warn them of the side effects. Some patients, you know, they just go on metformin. If they take it well, they see a difference. They just spontaneously actually fall pregnant. So don't undermine the use of metformin in women that are obese with PCOS. Warn them of the side effects, gastric side effects, nausea, and all of that. They can start with 500 on a day. Once they're used to it, then they can go back to 500 BD or 1,000 milligrams a day. Inositol, it does help in the quality of the eggs that are produced. At least 4,000 milligrams daily has been found to be effective. Very important to stress on life changes, exercise, diets. At least a 10% weight loss makes a difference. And metformin actually even helps with weight loss for some of them. And then ovulation induction. And if you give letrozole to a patient that has PCOS, please be very careful that you monitor her closely. You see how many eggs, because they can super ovulate. Those women, they've got lots of eggs, you know. So follicular growth is very important. They can go to ovarian hyperstimulation and all of that. Ovarian drilling is also an option if you have the skill. And then if you're not winning with IUI or ovulation induction, then straight to IVF. Some of them only become successful through IVF. And then how do we do intrauterine insemination? You need to know it is, I always tell my patient, it is a blind procedure. We don't see the egg fertilizing the sperm. We still just, you know, giving that sperm a 3-4 centimeter head start, you know, and it must still go and do the job. That's why it's important that the sperm that is being used must at least have a morphology of more than 4% or a total count of more than 4 million. If those are low, then they're still not going to be able to do the job, because they still need to swim for themselves. They still need to drill for themselves. And if they can't drill, then there's no fertility taking place. You can tell them that for this type of a semen analysis, then IVF is more recommendable. Anyway, it's only 10 to 20% success rate of IUI. For those who have when to do it, you do it for patients who have unexplained infertility, mild sperm factors, and ovulation disorders, patients like PCOS, patients who have PCOS, and so on. And then how do we do it? 2.5, sorry, it's not 2.4, it's 2.5 milligrams. I had written it properly in the previous slide. 2.5 milligrams twice a day from day 3 to day, from day 3 to day 7, which equals to 5 days. Or you can, so letrozole is a first line drug because it reduces the side effects on the endometrium and the uterine mucus and the penetration thereof. And also it reduces the number of follicles. So hyperstimulation is less, or multiple pregnancies is less compared to clomiphene. So you sonar the patient from day 8 till you get a leading follicle above 18 millimeters. You measure the lining, it must be thickened to about 8 millimeters. I also, depending where you are, but I also do an LH to see that the LH surge is beginning as well. Once you have an LH of about 14, you're lining, and then donkeys into hamang online, you know, then you know what you need to trigger. You give Ovitrel, and then you can plan your procedure to be between 36 to 40 hours later. And then pregnancy test in 14 days. Yay! Summary. A thorough history is very important. A good physical exam for both of them is very important. You do your sonar, look at the follicles. You can do an enteral follicular count. You can see if there's polycystic ovarian syndrome. You can diagnose your myomas, all of that. Then do day 2 bloods or day 2 or 3 bloods on day 2 or 3. Then the others, AMH, are not cycle dependent. Make sure you check those fallopian tubes. First line is an HSG. Second line is a lab scope, doing chromoperturbation if they have intra-abdominal disease. And then the male analysis, semen analysis for the males. Whoop, whoop. Yay. Whoop. I thought it was short. Oh, is it me talking too much?
Yeah. Dr. Riale, hey, wait, you need to come back, ne? I see people enjoyed your presentation. I've been laughing here. I wish I could have just kept my mouth, my mic unmuted so that you can hear the laughter to support you, so that you can see that you are not alone. But yes, again, thank you very much for such a very lively presentation. I know on your side it can feel like you are alone, but I think colleagues kept on giving you feedback as well.
Thanks for that, guys.
In many ways, yeah. So yeah, maybe colleagues, if there's someone who wants to ask a question live, you may raise your hand. We'll probably take one or two. But maybe just on the Q&A, I'll just summarize some of the questions that are there. You spoke about women and their eggs, that they are fixed. Someone is asking, what about the sperms? Do they also get lower with age? What's your...
So a quick one there. A sperm cycle is every 3 months. So men do make new sperm, but yes, there is male menopause as well. And the quality and the quantity of the sperm also reduces from the age of 40 gebona, at least, you know. So, but you do get about Zuma, you know. So I'll end there.
Yeah. And then tell us, Doc, in terms of this regular sex you are talking about, how do you define regular? You know, somebody's asking, sure.
Yeah, so regular sex is 3 times a day, guys. Yeah. I'm kidding. Regular sex is every alternate day or 3 times a week. Oh, sorry, man. At least 3 times a week. Not a day. It's not a TDS dose.
All right. So someone was asking about the use of, I think I've missed that, but there's a number of questions around other products. Vitamin D. I saw someone asking about triphysal. You know, do these have an impact on fertility? Are they known to improve fertility? I know triphysal as a contraceptive pill. I don't know if it... Tell us more, Doc. Thanks. Yeah.
So triphysal, probably for a woman who is not seeing her periods at all, and you want to trigger a period before you get started. Because when we say start letrozole on day 3, and they haven't seen their period for 3 months, you don't even know where day 3. So if you want to do it right, then you can put them on a triphasal, any COC, even an IVRA patch, once they start menstruating, then, but it does not reduce their fertility. And then vitamin D, yes, it has been said that it improves the quality of the egg, but we don't have much evidence to substantiate that, but it is a good supplement, even for pregnancy.
All right, let's hear from Tulani. Tulani, your hand is up and I've given you talking rights. You may ask your question live. Tulani, Bright.
Good evening, everyone. Thanks for the presentation. I would like to ask, after how long do you get back to into fertility after you've been using injectable contraceptives?
All right.
Okay.
Thanks for that. And maybe
it's usually a period of 3 months.
Yes.
It's usually a period of 3 months for most patients. Others can go up to 6 months. So what I usually recommend, if they've been using injectables and they quickly want to return their periods to return, go on it, stop the injectable, go on an oral contraceptive, at least for a month. You'll see your period and then your body takes over after that. It may seem like, you know, a reverse reaction, but it quickly regulates your cycle and then you can quickly see your cycle. Otherwise, you can just wait for your body to wait out. So it can be 3 months, for others, even 6 months.
Can you clarify further on that, Doc, with regards to contraceptive? Is contraceptive a risk factor for infertility? Is there a relationship between the two?
No, actually, it's a protective factor. Hey, can you believe it? Because when you are on a oral contraceptive, you don't ovulate, there's no rupture of the follicles or rupture of the ovary, and therefore no risk for ovarian cancer and all of that. So no, it does not reduce fertility, but the natural apoptosis or the natural death of the cell, of the eggs that happen, continue to happen on a daily basis.
Does that benefit include the use of an IUD?
Even with the use of an IUD, because but mostly IUD works locally, depending if it's, it works locally. I'm going to give you too much information.
All right, colleagues, will continue for another 5 minutes, and then we are likely to pause there. Jabulani Mkwanazi, you may unmute. I saw your hand is up. Please unmute. Yes.
Thank you, Dr. Mawela. I'm not sure if I'm audible.
Yes, you are audible. You may continue.
Yes. I'd like to thank you, Dr. Diale, for a wonderful presentation. It's really exciting. Thank you very much, my home guest. We're very proud in KZN.
Oh, the strong way, yeah.
Dr. Mkwanazi, yes, continue.
Sorry, I have a few questions. You keep on talking about letrozole. We are used to clomid. So if you can maybe clarify what does this letrozole contain? And number two, I'm not sure if you are aware, during the times when we had HIV a lot, when HIV was new to us, a lot of women would be sterilized after giving birth or after C-section. And now they are coming back to us some years later in the government sector, especially. How do you help those women? You know, if you can send them to some center where they can be helped in terms of infertility. Thank you very much.
Thanks, Doc.
The first question, Mkaya. Letrozole, as explained, letrozole compared to clomiphene, letrozole is an aromatase inhibitor. The mechanism of action is that, remember, at the ovary, the estrogen is formed from the androgens. So there is an aromatase, what do you call, an aromatase enzyme that converts the androgens into estrogen. Now, what letrozole does is it mimics this aromatase enzyme, and it inhibits the aromatase. So no more androgens are converted to estrogen. Then it tells the brain that, hey, we don't have estrogen. Then FSH is stimulated. Remember the supervisor. Hey, the ovary is not working. Supervisor stimulates more FSH, therefore more follicles are made. The difference between it and the benefits between it and the clomid, which makes it the first line now for ovulation induction, is that clomid goes and thins the endometrium as a side effect, less estrogen. So it thins the endometrium, and we don't want that. And it goes and makes the mucus plug very thick, so sperm cannot penetrate, and we don't want that. And it goes and forms multiple follicles, leading to a risk of multiple pregnancies, and we don't want that. So letrozole it diminishes all those side effects, and it becomes, therefore, the first line compared to clomid. I hope it
No, that is clear, Doc. And then, is there hope for someone who got their tubes cut long time ago?
Yes, there is hope. There is actually a case going on in the government sector, especially if you refer them to Steve Biko Academic Hospital. The HOD is busy dealing with that case, but their only hope then becomes in vitro fertilization. If they can afford it for themselves in the private sector, they can go straight for IVF in the private sector. But if not, then there are 2 centers in the Eastern Cape, it's a government, and there is one in which is Steve Biko Academic Hospital here in the government sector that is able to help these patients who have unfortunately been sterilized due to the diagnosis of HIV.
What's the typical cost for an IVF? I mean, what's the...
In the private sector, we're looking at 50 to 95K, depending on the center itself. In the government sector, we're looking at between 25 to 35K, because you buy your own medication. So, and they don't have to pay us. You know, the government will already be paying fertility specialists. There's no rent, there's no, you know, so it's subsidized fertility care. The only thing is that they don't take women that are above 40, and they don't, in Steve Biko specifically, they don't, which is here in Pretoria, they don't take women who are above 40 because the success rate is less, and this is people's tax money. And then you can go straight to the private sector, and we see how we can help you. And also people who already have kids, they don't assist them currently.
Okay. Yeah. So yeah. So before we take one more hand from Delaney, someone is asking, in primary ovarian failure, is there value in taking day 2 investigations?
No, because the person is probably not even seeing her periods. If she is seeing her period, then rather, so that we don't misdiagnose. But because some have primary ovarian failure, but still see their periods. But if she's presenting, she's 35 and she's not seen her periods for 12 months, there's no need for us to do day 2.
All right, cool. Delaney, you may unmute. Delaney? Delaney? I don't know. Yeah, okay, let me try another. Oh, yes, thanks. Yes.
Okay, good evening, everyone. Thank you, Dr. Diallo, for the beautiful presentation. So I have a question, a follow-up question from Tulani's about the combined oral contraceptives. So after starting these oral combined contraceptives for 3 to 6 months, depending on the doctor, obviously, to regulate their period, is it possible for periods to stop after they had been stimulated by the COCs? And if they do stop, what is the next measure to be taken? Thank you.
All right.
Okay, Delaney, you know what, dear, it depends what is the cause for them to stop. If you are treating a patient with primary ovarian insufficiency and you're giving her COCs for 3 months, then you are basically giving her false hope of menstruation. After that, it will stop because the body won't kick in. It's just makeup, you know, it's just superficial window dressing kind of thing. If she has a PCOS, for example, and you regulate for 3 months, the moment you stop, then the PCOS, you know, because the cause has not been treated. So yes, there is a possibility that the periods will stop until we find out what is the real cause of the woman not going on her periods spontaneously. So regulation with COCs is only temporarily. And I never would put a woman who wants to fall pregnant on a COC for 3 months. That's too long. You know, just 1 month, see what's going on and get her started on ovulation and see what's happening. But 3 to 6 months, time is man.
Doc, there's a question here to say, how do you advise a couple who wants a boy because they have more than 5 girls? I'm asking this because this one, even for me, I only have boys, and I've been saying, if I can have a daughter, is there a way of...
Doc, Dr. Mawela.
Yeah.
How much money do you have? Let's talk.
Oh, that's the first question.
Look, guys, is this thing being recorded?
Yes. We are recording, Doc.
Let me tell you, if they want a certain gender, it is illegal in South Africa to do gender selection. Right. So you see, now I'm keeping a straight face. Hey, guys. We do IVF, and there is a process called PGT, where we test for genetic abnormalities in the baby for people who've had a previous Down syndrome or people who have advanced maternal age, they're above 37, wara, wara, wara. And then we get the genetic makeup of every embryo. And part of the 23, the 46 chromosomes, we get this set, which is called XY or XX. So we get to know under general, you know, what's happening in the pack of all the embryos, because we were testing for DNA abnormalities because of advanced. Angazi noma niyangithola noma ngizongithola later noma niyangitolerate.
We hear you on the sideline, Doc. Before you get arrested, let's ask Tepiso to ask Tepiso Sibego. You may ask your question. You may comment or ask a question. Thanks.
All right. Can you hear me, Doctor?
Yes.
Hello.
Thank you.
All right. Thank you for the opportunity. I wanted to say that was a brilliant and energetic presentation. Thank you so much. My question is based on irregularity of menstrual cycle. If, let's say, a woman or a female, her partner has irregularity menstrual cycle, sometimes it goes for 4 days menstruating, there are sometimes 7, sometimes 3, sometimes it's late, they're actually not even sure of their cycle exactly. How do you, like, what can be done to actually try to regulate it? Or the question was, does it affect the woman to be falling pregnant?
All right. Thanks, Doc. Thanks.
Okay. So the main time when we worry about a period really and the cycle is when a woman is trying to fall pregnant, and if she has very heavy bleeding, because she can be anemic, you know, that can make her sick. And if a period, you know, women have this understanding that this is where educating a patient empowers them. They have this understanding that no, the period it's 15, you know. So the period 15. But educating them that if you have a 25-day cycle, you can menstruate twice in a month. That is normal. As long as your cycle is between 21 to 35 days, it is fine. And these apps that they use to say, it was supposed to come on this day, junk in, junk out. So if you give it information that is incorrect, it will give you, because it's just like a calculator, it estimates. So does it affect a woman's cycle? I mean, fertility? Mostly not. As long as the woman is having her period, what's important is to check whether she's ovulating or not. And the least she can do is to buy an ovulation kit. If very cost effective, maybe it's like 150 Rand. That's the cheapest way for her to check without involving us. Over the counter, buy an ovulation kit. From day 10 of a period, wake up every morning, test your urine like a pregnancy test to see if you are actually releasing an egg or not. And if you are releasing an egg, whether your period comes after 25 days or 32 days, it's not really a problem. Sometimes, you know, we end up over treating where it's really not necessary.
Okay, Doc, we have 5 hands. I want us to take them in a marathon. But before I ask Dr. Tulani to comment, you spoke about the supplements to boost the male fertility. Can you talk a little bit around that, and also if there's specific supplements for women? Thanks. There was a lot of questions around that. Thanks.
No, but it's things that are common in the market, you know, where men can try both Sperm I-Proof, they can try Prelox, you know. It works on the quality of the sperm. They are basically antioxidants. So whatever could be destroying the morphology and all of that, there's stamina grow, all those things for men. There's bosinopol for women. There's picositol. There's Insumex Q, especially for those that are, diagnosed with the PCOS. There is I wanted to say these other ones now that I'm forgetting. There's ovaria that have inositols. There is fatty pill for men and for women. So those are just, you know, additions and cherry on top to just try before we go for the big stuff.
Yep, Doc. So I want to do this last 5 minutes this way. Colleagues, exactly past, we are stopping. I see you are all still here. And I'm sure Dr. Yali is also, she won't tell us, but I know that it's exhausting to teach. So let's take these hands. I'm going to take them in sequence, Doc. And then you will then, unfortunately, Tabudi, we won't be able to take your hand. We're going to close with Dr. Badlago. We can only take 5 hands. My apologies for that. The only thing is that we can agree that, Dr. Riale, you need to come back. It seems like people have a huge interest in the topic, and I think it's probably a very important topic, and we can look at specific, you know, interventions in the near future. Let's start with you, Dr. Koza. Please, one question at a time, and then after that, we will summarize these questions. We'll just take the last few hands. Thanks.
Thanks, Lisejo.
Yes,
which is the better specimen, straight from the male, masturbation, or pipetted from the vagina post-intercourse? You remember the story about hostile vagina. So I wanted to make sure which is the best specimen for semen analysis.
All right. Thank you, Dr. Koza. Doc, please don't respond. Let me take the last few hands and then we will try and cluster them. I can't see the full name. Moneiwa, thank you.
Thank you, Doc. I just want to ask the link between metformin and early pregnancy loss in patients with PCOS. Thank you.
Thank you. Kutazwa Toshe. Oh, I didn't give you talking rights. My apologies. Kutazwa. Yes, you may unmute. Kutazwa. Okay, we move on. A few seconds. Matlodi. Are you able? Just wait a minute. No, where is this thing? Give me a few seconds. Let me reduce the number of people. Okay, cool. Okay, it's not there. Okay, Dr. Mahlangu. Dr. Mahlangu, are you able to unmute?
Yes. Can you hear me now?
Yes, thank you. You are the last one, Doc.
Actually, I posted the question there, but I can say it since you picked my hand. Hi, Doc. Very good presentation. Thank you so much. I just wanted to find out here, because the clomid and the lateral works differently in different areas. The clomid working in the brain and the lateral working on the ovaries. Can we use both simultaneously?
All right. Thank you. Doc, I think you have 3 to reply to, and then that will be all for the evening. Thank you.
All right, I think I'll try and remember them. Maybe let me answer the last one first. No, it is not recommended to use them both because then you will have an imbalance on the estradiol levels. You will lower your estrogen too much. And so one at a time. And then the one about the best semen sample, the masturbated sample is said to be better because you have the actual volume, you can assess the volume, and it is not affected as yet by the acidic vagina. So you've got more parameters that you can actually assess as far as the semen analysis is concerned. There's no loss. And then the other one was metformin and early pregnancy loss. Look, metformin is actually recommended, as mentioned, especially in women with a BMI of more than 30. And yes, women do continue actually to use it even in early pregnancy. So not much association there.
All right. Thank you very much, Dr. Riale. Yeah, it was an interesting, very empowering session. Would you like to say your closing remarks and then we call it a night? Thank you.
I just want to thank everybody that attended the talk. And, you know, they say iron sharpens iron. And if we are empowered doctors and knowledgeable doctors, then we are able to take the knowledge and apply it well. And it's for the benefits of our community. So I hope we're going to apply all the information that we have learned today. And I'm sure it's going to make a difference to the people who will be sitting in front of us. Thank you very much.